too. We really enjoy working with her and her team. And I'm sure you will learn a lot from her presentation, but most importantly, as we say, for this seminar series is not only about the research she's doing, but also she would share with you some of her insight about graduate study and so on. And feel free to ask a question related to some of the your real life encounter, especially in this difficult, challenging time. And she has a tremendous wisdom and experience to really light you up. And so today's talk she's going to give is the use of a technology for management of pain and symptoms of children with cancers. Michelle, please go ahead.
Thank you, Professor Lee. I appreciate that wonderful introduction and the opportunity to be here today to talk with everyone. I've been at UCI 12 years now, and it's been a great fortune for me to have been introduced to Professor Lee early in my career. And we've had just wonderful collaboration with the team at Cal IT2 and Cal Plug, and I've just gained so much from this collaboration. So I'm thrilled to be here today. I think the programs that come out of the partnership with Cal IT2 and Europe are just wonderful opportunities for our students. I'm very grateful that we have a SURF-IoT fellow as well. So again, thank you for having me. And I look forward to talking with you today. I'm going to go ahead and share my screen. Try this again. Okay. Here we go.
Yeah, it works.
Is that okay?
Yes.
Okay, excellent. So as Professor Lee mentioned, I'll be talking with you today about of mobile health technology in the context of healthcare, and there are just so many benefits to doing so. I think one of the things that is a little bit unique about our program is that we see a lot of technology being used in terms of assessment of symptoms and really complementing what we can do with in-person visits in healthcare settings. And so we have definitely incorporated that, but we're also using our programs to deliver behavioral interventions to really reach a broader audience of children who can benefit from interventions but may not have access to them. And so I'll describe how we're doing that. And then I'd love some opportunity to discuss, at the end, what are the benefits, but also the challenges to using technology in healthcare, because there are many on both ends. So as Professor Lee mentioned, I am co-director of the Center on Stress and Health, and we are a multidisciplinary research center. I'm a huge proponent of team science. I joined the School of Nursing just over 2 years ago. Before that, I was in anesthesiology. So in nursing, I teach a graduate course in translational science. And we typically think of translational science as kind of bench to bedside, but we really take a larger view in this course on essentially bedside to practice. How do we get these interventions out into practice? How do we change healthcare? And that's really the focus of our center, is how do we change the practice of healthcare? And in order to do that, you really need multidisciplinary teams or interdisciplinary teams. And so we largely work with a variety of healthcare specialties, but we also work with folks who are doing this technology work. So all the folks at Cal IT2 are computer scientists or engineers and so on. And we really focus on how do we make having to be in a medical setting a better experience for kids and families. So how do we minimize pain? How do we minimize anxiety? How do we improve quality of life? So we largely focus on family-centered care, and we incorporate a lot of integrative health, integrative medicine. So what are complementary and alternative strategies that we can incorporate into our interventions? We also, because we are physically housed at Chalk Children's Hospital, we have a large focus on how do we reduce health disparities in our children. At Chalk Children's and in the oncology setting, we have upwards of 60 to 80% of our patient population is Spanish speaking, typically Mexican-American background, and we see a lot of disparities in pain and other psychosocial outcomes in our Spanish-speaking families. And so we are really working hard to identify sources of those disparities and then implement interventions to minimize those. I today would like to cover, largely focusing on one of my interventions that has comprised most of my career here at UCI, but we'll talk about some barriers to optimal pain management in children undergoing cancer treatment, and then describe the use of mHealth or mobile health to deliver behavioral interventions for pain and symptom management, and then hopefully be able to talk about some of the strategies that we are integrating into our interventions. Just to let you know, this program of research has largely been funded by both the American Cancer Society and then more recently by the National Cancer Institute. Otherwise, I have no disclosures other than I'm quite passionate about the work that I do. So as much as that can lead to any bias, I can't always help that. So just to kind of set the stage for this work, why the focus on pain? There was a report by the Institute of Medicine in 2011 that was focused on pain called Relieving Pain in America. And this report highlighted the prevalence of pain, showing that both chronic and acute pain are highly prevalent across age ranges. So there's kind of this misconception still even in healthcare that children don't experience pain like adults do. I'm trained as a pediatric psychologist and my specialty is pain management. And for years I had a practice in our pain management center at Gottschalk Plaza here at campus. And my practice was treating kids with chronic pain. So kids have chronic pain at the same prevalence rates as adults do, things like chronic headaches, chronic abdominal pain, back pain, and so on. So it's highly prevalent, and it is unfortunately associated with a wide range of negative impacts on functioning. Kids and adults with chronic pain are unable to go to school, unable to work, unable to engage with friends, or just essentially engage in the roles that they're expected to and want to in life. There's also a huge economic impact of pain. A report by Johns Hopkins showed that the cost of chronic pain is $635 billion a year. It's just staggering. So there's a huge need in terms of the social impact, but also the economic impact of pain. There are also evidence that shows that there are disparities in the experience and treatment of pain. So underserved population, ethnic minority populations, children, elderly, individuals from lower SES backgrounds are all at higher risk for pain and poor pain outcomes. There's also good framework within population health and public health areas that show how we can intervene with pain and address prevention at both the individual, so how do we work with individuals on pain prevention, but really largely on populations. How can we prevent pain in larger populations? And that is my focus in terms of that population level is the oncology setting. So what we know is that, a few decades ago, pain was a huge focus in terms of research. Children and adults who undergo treatment for cancer have to undergo a wide range of painful procedures. And prior to a few decades ago, there weren't really good interventions for these painful procedures, things like bone marrow aspiration, lumbar puncture. And so kids were awake as they were undergoing these procedures. And so a lot of people were figuring out, how do we help kids get more comfortable? Then came the era of conscious sedation, where we essentially then sedate people for these painful procedures. And when that happened, people stopped really looking at pain during cancer treatment. And what we know is that cancer is very prevalent. And when we look at the sparse literature there is, especially in children, what it shows is that the overwhelming majority of kids who are going through cancer experience pain throughout their treatment trajectory. And an important thing to consider when it comes to children is that the most common diagnosis of cancer in children is leukemia. And leukemia, the treatment for leukemia typically spans 2 to 3 years. So children are really subject to a long period in their life, if they have leukemia, of being subjected to painful experiences. And pain during cancer treatment can be caused by a variety of things. Sometimes the cancer itself causes pain. The treatment can cause pain. Chemotherapy, for example, can cause nerve pain. Radiation can cause skin damage and pain. There are procedures, skin breaking procedures that are painful. So there's a wide array of reasons that kids undergoing treatment for cancer will experience pain. But what we know is that most pain during cancer is caused by the treatment itself. That means it's iatrogenic. So the things that we're doing to help kids survive cancer is also causing them pain. There have also been advances in treatment for pediatric cancers. In fact, recent data show that over 80% of children with cancer will survive. And these advances really come because there have been advances in treatments. What this means is that the treatments have become much more aggressive to treat the cancer, and therefore they also cause a lot more pain and other symptoms. We've also shifted the way we deliver our treatment. When we look a couple of decades ago, most children with cancer were hospitalized for their treatment. Now, most cancer treatment is delivered outpatient. And that's great for quality of life. Kids want to be home with their families. Families want their children home. But the challenge is then we've really transitioned the responsibility for pain and symptom management into the hands of parents and caregivers. And what we haven't done is adequately equip parents and caregivers to manage those pain and symptoms. And so when I joined UCI back in 2008, I came from training in chronic pain management in children, and that was my plan. I'm going to continue on with chronic pain management, and then I came here to UCI and realized we didn't have a population of kids in chronic pain because we don't have a chronic pain treatment center here for kids. And I realized that people weren't focused on pain in children during cancer, and at CHOC we have a large population of children with cancer. And so I essentially transitioned my program of research to focus on the pain experience of children with cancer. And we started this in, I think we can safely say, a fairly logical approach where we essentially started with descriptive studies. Let's survey kids and parents and understand what their pain experience is and what are some of the factors related with that pain experience. And so these are just some examples of this program of research. And what we found is that parents have many misconceptions about pain in children and how to treat pain in children. For example, believing that if my child is in pain, they will always tell me, it will be obvious, that I shouldn't give my child pain medication until pain is very severe, and I shouldn't give it that often. And all of these are actually counter to optimal pain management. We then looked at what was happening in the home setting of children being treated for cancer. And we followed 50 kids for 2 weeks, and we asked them to complete diaries every day, reporting on their pain experience and on parent administration of analgesic medication at home. And what we found is that at least half of the kids were reporting chronic pain experience, so pain that was recurrent. And only 40% of the kids got pain medication at any point during the 2 week. However, the median number of doses administered over those 2 weeks was 0. So most kids just got no medication. And on every single day of the study, there was a child that reported clinically significant pain, but received no pain medication. And on some days it was up to 20% of kids reported pain. So clearly we were seeing that there's a problem with pain management in the home setting. We then wanted to kind of better understand what are some of the factors that might be associated with the pain and symptom experience in the home setting. And we identified factors such as anxiety in parents was associated with higher reports of pain in children. And when parents engage in what we call solicitous behaviors, and these are behaviors that parents and caregivers may show when they're essentially worried about their kids and want to take care of them. So they're protective behaviors. But those were also associated with higher rates of pain in children. And then we found that children from Spanish-speaking families whose parents reported higher levels of anxiety had a poorer quality of life during cancer treatment. And so we started to kind of put together a picture of what are some important aspects that we need to consider when we think about interventions and how to improve the pain experience of children. And so overall, we have shown with our research program that pain is high in children undergoing treatment for cancer, that there are many barriers to optimal pain management and quality of life, and that this really is an important area in which interventions need to be focused. And so that then led us to how can we intervene? We also have to consider that the opioid epidemic is a concern, and we have to think about how do we factor that in to our interventions. There have been significant increases in opioid-related overdose deaths in the last few decades, and these increases are also shown in adolescents. And most adolescents who show concerns with opioid misuse, it has stemmed from a prescription opioid. We also know that patients with cancer are considered unique populations when it comes to studies of opioid use. In fact, patients with cancer are excluded from clinical trials and state legislation regarding opioid use. And because cancer pain is so unique, opioids are often first-line analgesics. In fact, over-the-counters like ibuprofen, NSAIDs, acetaminophen are avoided oftentimes in patients with cancer because they can mask important signs like fever. We really want to know if someone with cancer is experiencing a fever. So it's often that opioids are the first line treatment. So we need to really also better understand how opioids are being used in even kids with cancer. So we decided that a novel, innovative way to intervene in cancer pain management was to incorporate technology. And as I mentioned, and Professor Lee mentioned, we began our partnership with Cal IT2 in order to develop interventions that could target this issue, but also be engaging, enhance the treatment capabilities that we had at the time, and really be able to be something to be accessed by almost any family that wanted to use this type of intervention. And so we started first with our Pain Buddy intervention that I'll detail. It might be obvious to you all why we went the technology or digital health route, but many of us are doing that in healthcare, incorporating technology into our interventions or in the delivery of our interventions. And really this reflected at the time two transformational trends that we were seeing in healthcare. One was this pressure to deliver high value care. There have been changes to reimbursement in healthcare that are basing reimbursement largely on patient satisfaction and patient experience. So if we can improve the experience of patients in healthcare, then that helps the economic bottom line. There's also been really a digitization of our healthcare system. When we think about what patients are used to and what they're expecting, they can now access medical records by hopping on their computer or smartphone to communicate directly with their healthcare providers. So there's becoming an expectation on the side of patients that healthcare is going to be digitized. So when you you hop onto the Apple Store or the Google Store, you'll see just endless healthcare apps. The challenge is that when we look at the evidence behind the majority of these apps, there's essentially none. So people are developing these apps like crazy, but they're not showing that they are actually effective and do what they aim to do. And so we really set out to develop evidence-based interventions that do what they aim to do, that we can then disseminate more largely to a broader patient base. We also just want to follow what's called an orbit model. So this is a model that guides development of interventions in essentially behavioral science or social science research. And the importance of following this is that it really provides the necessary evidence and justification to get from your target, your clinical question, all the way to dissemination. And the nice thing about this orbit model is, although it looks linear, you're actually kind of going back and forth in between phases. For example, when you're doing your preliminary testing, you might identify some changes to your intervention, so you kind of go back to phase design. But ultimately, what you want to be able to do is collect enough data to show evidence that your intervention impacts your target outcome and is meaningful to the population for whom you've designed it. So this gets us to Pain Buddy, which essentially has been my baby throughout my career here at UCI. So Pain Buddy is a web-based program. It's interactive. It's geared for children ages 8 to 18 undergoing primarily outpatient cancer treatment. The inpatient setting is a little bit different, although our kids, what we see is that kids undergoing treatment for cancer will sometimes go back and forth from an inpatient to an outpatient setting. And so our kids who go inpatient often take their Pain Buddy with them and use it in the hospital. So essentially, Pain Buddy is comprised of 3 components. We created a symptom assessment, essentially a daily diary of pain and symptoms that is remotely monitored by the treatment team. What we did was we took validated measures of pain and symptoms related to cancer in children and incorporated them in an electronic format, but also instead of just kind of reporting on their answers, we made it more game-like. So children are asked if they have symptoms and they can swipe their balls into the yes or no basket, and then they're asked follow-up questions about those symptoms. The remote monitoring piece is because we want this to be a very clinically relevant intervention. You know, it's one thing for us to get all this data about, you know, the symptom experience of kids, but if we can't act upon it, then it's not clinically relevant or useful. And so we worked with the oncology team at Chalk Children's Hospital, largely a group of oncology nurses. And we said, at what point would you want to know? At what symptom level or threshold would you want to know so that you could act on these symptoms? Because what we know with these daily diary type programs is you get a lot of data, a lot of information. And we didn't want healthcare providers to be inundated with all this information. So we built in symptom alert algorithms that notify healthcare providers in real time. So the minute that a child reports those symptoms, the healthcare team is notified. And it tells the healthcare team exactly what symptoms a child is experiencing and at what level, so they can act in real time. The second component is that we wanted to actually have the program, the app, be an intervention itself. So we know that pain is extremely complex, and in order to treat it appropriately, we need multimodal intervention. So analgesic medication is one part of that, but It doesn't address pain in its entirety, and it comes with a lot of side effects. So we wanted to complement that pain intervention by teaching skills, evidence-based, teaching children evidence-based skills to manage their pain. So things like deep breathing, mindfulness, progressive muscle relaxation, distraction. So the program actually teaches kids these skills and gives them opportunity to practice so they can develop some efficacy. And then the entire program is navigated by animated 3-dimensional. So the avatar walks the child through the program, teaches the skills, helps them do their symptom diaries, and so on. And this is just a kind of a visual of how this remote monitoring and electronic communication piece works. So a child inputs their symptom data, it goes into a server. Those algorithms either trigger a notification to the healthcare provider if a symptom warrants intervention, at which point the healthcare provider will communicate with the family, and then the skills training is also triggered. This is just a bit more information about the symptom diary, what tools we used, and the questions are delivered based on how a child answers them. So for example, if I swipe that pain ball into the yes basket, I'm going to get some follow-up questions about pain in terms of the severity, the frequency, and the bothersomeness. And then this is the skills training page. And really our goal is to empower children to be able to have an impact on their pain experience at home. And so we have 14 tutorials that we have built into Pain Buddy. And the tutorials can be accessed anytime the child wants. And in fact, we are hopefully motivating kids to access those, because we think this is one of the active treatment components of this intervention. And so we want them to practice these. And then again, they're brought to the skills page whenever they trigger this algorithm. And then to make it more fun and engaging, we built in a Pain Buddy store. So children can get virtual coins every time they do their required diaries and when they complete skills exercises. And then they can use those coins to really personalize the program. They can change avatars, they can get clothes and other accessories for their avatars, and just to make it more fun and game-like. What we also learned from our early trials with this is that we really needed to engage kids in this for them to use it. So our subsequent iterations, we built in more gamification of the app. And so kids have a number of different games that they can play. They unlock the games by engaging with the diaries and the skills training. And then we've also built in a leveling system to encourage kids to use those skills. So every time they practice, they kind of advance in their levels, and we're using a martial arts kind of analogy so they can gain different color belts to hopefully they can earn their black belt in the skills training. And so we have originally published on the development and formative evaluation of Pain Buddy, and essentially what were the steps and the components, and what was the response of the families who tried it. Kids have really enjoyed the program and gave very positive feedback. And then we went to the next step to do this efficacy trial. So we recruited about 50 kids, and we had them use the program for 8 weeks. They were either randomized to the intervention or just to doing the symptom diaries. And the reason we did that was that there is some evidence that simply monitoring your pain and symptoms can impact your pain and symptoms. And so we wanted to essentially control for that. And then we looked at a variety of outcomes. But what we showed in this preliminary efficacy trial is that when kids were randomized to either that full Pain Buddy intervention group or just the monitoring group, that their pain severity over the course of those 8 weeks was lower in the Pain Buddy group than it compared to that attention control or monitoring group. And the largest effect sizes we saw is for the worst pain experience that they had on average over those 8 weeks, with an effect size of 1.1, which for a Cohen's d is considered a fairly large effect size. So we were very happy with these early results. We also showed that kids in the Pain Buddy group also had fewer moderate to severe pain episodes. So when we looked at the number of pain episodes, there were many fewer in the Pain Buddy group than that attention control group, and that those kids also experienced less interference in their functioning as a result of their pain. So this early data actually allowed us to get the R01 from the National Cancer Institute. And so now we're in, we actually just started year 3 of this 5-year grant. And we are now looking more broadly at the effectiveness. So we have 2 sites at Chalk Children's and St. Jude Children's Research Hospital. And we're recruiting about 200 children across both sites, again, to either get full Pain Buddy or the attention control. And now we're looking at a broader range of outcomes and potential mediators and moderators of this treatment effect. And our goal after that would be larger dissemination. And I hope in the discussion period, we can talk about some of the challenges there. And then I just briefly want to go through, it's clearly important to target the experience of children. But we also, as I mentioned earlier, we need to equip parents to better handle pain and symptoms at home, because parents not only have misconceptions and misunderstandings about how to manage pain, they also just don't have the tools that they need in order to respond to their children's pain effectively. And so also working with Cal IT2 and with funding from the American Cancer Society, we developed a companion parent program called CTIPS. And this program, originally we wanted to develop a stress management intervention for parents that included some training about pain management. The stress management part was more challenging than we thought, which is often the case in research. You have to switch gears. But the idea with this intervention was that the intervention would be tailored to a child's specific illness and treatment journey. So parents would get relevant information. And then parents would go through and provide some information to tailor their relaxation component or their stress management component. And then parents were trained in diaphragmatic breathing and allowed opportunities to practice that. And then we're able to go through this pain management intervention that we called COPE. And originally, this was going to be a biofeedback intervention. And at the time, we worked with Dr. Mark Bachman at Cal IT2, and we had this wireless glove that collected heart rate variability. And we wanted to feed that back to parents to help them manage their stress. We found that a lot more challenging than we anticipated. And so we ended up dropping the biofeedback piece. We still give parents the breathing training, but we don't have the biofeedback piece. And the idea is that, the evidence shows that parents who have children with a cancer diagnosis understandably report higher levels of stress and poor quality of life and poor physical health than parents of healthy kids. So managing that stress is really vital for parents of children with cancer. So this just gives a little more detail about the imagery that parents could view while they're doing their relaxation training. This is just some examples of how we covered the pain management instruction. We did it in a question answer format. So we solicited questions that parents have about how do I manage pain in my child as they're undergoing cancer treatment. And then we provided specific information and training to address those. So for example, for a child who might be having a blood draw or a port access or a lumbar puncture, how do you help distract your child? How can you coach them to get them focused on the distraction, for example? And then we brought in 30 parents to use the intervention and give us feedback, both through interview, and then we also collected some quantitative data as well. And overall, parents liked it. They thought it was helpful and relevant. It helped them relax. In fact, when we got pre and post ratings of relaxation and stress, there were improvements in both areas. We didn't see any difference in the physiological data, which made sense in just a one-time thing. Sorry, I went ahead too far. And now we're in the process of how do we revise this intervention and make it more clinically meaningful and also more tailored to diverse populations in the oncology setting. And so we actually have funding from Alex's Lemonade Stand Fund, and we're developing a broader intervention for our Spanish-speaking families that addresses parent stress and quality of life with a number of innovative components, particularly now in the pandemic when we can't do any in-person interventions at the moment. Using technology is especially important right now. So that's where we're at with the parent piece. And so really the overall goal of this research program is to improve quality of life for children and parents during cancer treatment. And I'm so thankful again to have the opportunity to work with both CAL-IT2 and the Undergraduate Research Opportunity Program at UCI to provide these opportunities for us as faculty researchers and for our students to gain important and necessary skills to move forward with your career goals. So I want to thank Dr. Sergio Gago and his team, who we've worked with for the past many years, Dr. Mark Bachman, who was instrumental in CTIPS, part of my team at the UCI Center on Stress and Health, Heidi Cortez and Leslie Torres, who, without whom I would be nowhere with these projects. They really are the people who are on the ground making these things happen. And then Preview Labs, who's also a company that we've been working with to do some of the visual design with Pain Buddy. So I will stop for questions, and then I also have some time for that.
Thank you, Michelle. So now is open for questions.
GP, I have a question.
Yes.
It's Shelley. As a parent of a certified child life specialist, I'm wondering, Michelle, if you have considered, or if you do collaborate with that type of specialty.
Yes, thank you. Thank you for raising that question. We do. We've had close partnership with certified child life specialists at CHOC who provide such a vital service for our children to help them get through these difficult and painful procedures. So child life specialists were involved in the development of both Pain Buddy and CTIPS in terms of kind of the language that we use, which is critical when talking with kids, using non-emotive language to keep anxiety levels down, as well as strategies for distraction and calming and managing that procedural anxiety and pain. So absolutely a vital part of our team.
Okay, I'll share with my daughter. I'm sure she would be very, very interested in this work.
Is she local or?
She's up in Glendale.
Okay.
Right now, she just got her license in July, became certified in July. Wow. So this situation is lending herself not being able to really get out there and find work.
Yes, yes.
Thank you.
Of course. Thank you for the question.
I have a question that I can ask.
Yes, please.
Hi, so I'm Aviv. Hi. My question is just, you said earlier that the Pain Buddy's meant, or that it was designed for people of ages, or children of ages 8 to 18. Mm-hmm. And it just made me think that if you're comparing someone who's 10 years old versus someone who's 16 years old, I'm sure that it would be difficult to find something that would be engaging for large age, different age demographics, have an application that would be engaging for them to interact with. So I was just interested if in the design and presentation of the app, if there was considerations about how to make it work for someone who's 8 and 18.
Yes, thanks for raising that question. And that is another really important question. So absolutely, it's a broad age range. It's probably, you could argue, too broad. And there's a delicate balance when it comes to the development of these interventions, because technological interventions, a downside is they're not cheap to develop. And funding agencies like NIH or other federal agencies are not keen on giving money for development. They want you to come in with an intervention already developed, and then they'll give you money to test it. So we really had to kind of weigh the pros and cons of limiting the age range so it was very developmentally appropriate, knowing that we're not going to be able to develop multiple iterations of this because of the cost. So what we did is, and this was a years-long process in terms of this development, we engaged patient stakeholders every step of the way. So each component we took into the hospital and we had kids review it, try it, give us feedback, and we stratified that feedback on different ages. So we focused on kids 8 to 11, 12 to 15, 16 and up. And we looked the entire time for differences based on those age groups. And what we ended up finding is that we didn't have differences. We did tailor the measures used to be developmentally appropriate. So the way we assess the information is age specific. The interventions, as far as the skills training, are not. I think probably the biggest piece for the engagement and interaction is the visual design and the user interface. And I think there's definitely room to make some changes based on age there. And so when we think about our next steps, that is definitely on the list. How do we, now that we have, you know, kind of the heart of it, how do we then start to tailor it to different groups?
That makes sense. Thank you.
Mm-hmm. And we're actually working with a group at Sick Kids up in Canada for a similar program, but for parents of young kids, because the majority of kids with leukemia, for example, which again is the most common cancer diagnosis, are young. You know, they're diagnosed when they're 3, sometimes even younger. So, and there we need really an intervention focused on parents. So right now we're taking an intervention and redesigning it for parents specifically.
Thank you.
Any other questions?
Michelle?
Saeed? Yes.
Yeah, Michelle, if I may follow up, I apologize for joining late. I had another, and we've always admired your work, and I don't know if you already touched on that, but you have a unique journey, and the fact and the way you have touched different disciplines along the journey. Could you elaborate a little bit more on that and open our eyes to this multidisciplinary, interdisciplinary, and also for the student's point of view,
Mm-hmm.
what should they anticipate the future in that context to be like?
Thank you, Saeed, and thank you for joining. I appreciate that you could be here. And for that question, I mentioned at the beginning the importance of team science, but did not elaborate. So I appreciate the opportunity to do that. In order to, when we think about, again, that translational approach, if we want interventions to change practice, the only way that's going to be successful is if you have, you know, an interdisciplinary team or a multidisciplinary team, because you cannot get the perspective of all the important players that are really going to open those doors for you to change practice without a team. So for example, I can develop an intervention that I think is important, but I don't understand the technology needs for it or the technological considerations as a psychologist. So I need to partner with the folks who know that. But also more broadly speaking, I don't know what is going to make hospital administrators say, yes, we want this intervention. We want it to be standard of care for our patients. So we will adopt it. I don't know what is going to make our child life specialists or our nurses say, yes, let's get this to our patients and let's make sure it's available for them. I don't know from families' perspectives, what's going to make you engaged in this and your kids use this, and what's internet access like in our population. So without those perspectives, you may develop an intervention, but your chances of actually getting it out there and having a real clinical impact on what's happening are very, very low. And so it's really important at the outset to identify the stakeholders that may have a say in your long-term goal. And part of the challenge in our field is that many of us are short-sighted when it comes to that. And without those stakeholders at the beginning to kind of plant the seeds for how we need to go about this, you really limit your chances of success. And what I've learned in my journey is that you're always identifying new stakeholders. I need to think about, is this something that insurance will end up covering because it is a clinical intervention? Is this, something that, we've just encountered so many barriers throughout this that I wouldn't have anticipated because I didn't have that perspective. So, how do we make this available to families without having to go through the Apple Store? Is that even possible? There are just lots of considerations. So I think this is really the future for anyone who wants to, be involved in interventions for healthcare or interventions that are, impacting actual people's lives and experiences. That team science is critical in order to have the impact that you want.
Thank you.
Yes,
I think you raise your hand. Question. Yao Du, right? Yes, please. You are muted. You need to unmute yourself.
Sorry, I didn't get my hands on the mute fast enough. Thank you, Professor, for this wonderful talk. I learned about your work from John Hunter, also a fellow PhD student. So it's very fascinating to see the implementation of mobile health for children. I was just curious to learn, during my own line of research, I also encountered a situation where we designed the technology initially for the children, but we realized we have to treat family as a unit. I was just curious to learn, are there any potential plans down the road to design a potential application or program where you children and parents can co-engage together rather than this program is just for the children, that one is for the family? It feels very segregated and isolated.
Yeah, great question. I appreciate that. At the outset, that was our goal, was to have a more comprehensive intervention that addressed the family as a unit. And again, what I've learned in this work is that there are a lot of constraints as you're developing, but just because it can be very challenging to get the funds to develop, what your ideal vision is. So we scaled back. But our plan is definitely to really enhance this as more of a family intervention. We've done this successfully in the surgical setting. So we've developed what I would say is a really nice preparation intervention that prepares children and families for surgery when children are undergoing surgery. And that program is really family-based. It has a fully animated component for kids that kids do with their parents. It has a component for parents, and it actually also has a component for healthcare providers to give them information about the family that is going to help tailor their treatment. And that's really our vision with these interventions, is how can we address the family as a whole. So I think Pain Buddy could probably keep me in business for life because of all the different things that, we can do to enhance it and improve it. But that's definitely on our list, is to have a more comprehensive family-based intervention.
Thank you.
Thank you for the question.
I really want to encourage the fellows, the SURF-IoT fellows, to also ask questions. This is such a unique and golden opportunity to be with Professor Fortier and engaging her work. And so could I ask the fellows to turn your cameras on and please ask any questions you feel are appropriate and follow up to what you heard.
And I'm going to stop share so I can see those who do.
So Darwin, Judith, Melinda, Vikram.
And I won't put Judith on the spot with making you just ask a question or say anything, but I also want to acknowledge that Judith is our fellow in our lab and has been very involved with our oncology projects, including Pain Buddy. And we are so thankful that she's a part of our team and just been really a vital and important part of our team.
Thank you. Thank you very much for that, Dr. Fortier. I really appreciate all your mentorship that you've given me since the start, for first granting me the opportunity to join your lab.
Oh, thank you.
We envy you, Judith, for working with Professor Fortier and the wonderful team she has. So we have a couple of minutes. Anant, what do you think? Melinda? Anyone?
I could ask another question. So,
Hold on a second. I think Anant was prepared to ask a question, no? Okay, it's not working. All right, Aviv, go ahead, please.
I was just curious about, because you talked about how the Pain Buddy then could, like, in real time give to healthcare providers so that they can be aware of the symptoms that are happening and can try to give possibly interventions based off of that. What type of, considering like, at least like now, that it's hard to be like send someone to physically go in person help someone who's like might need an intervention, what type of remote interventions could healthcare providers give as an example? I'm just interested to know.
No, that's a great question, and especially now when we're relying more and more on remote interventions and remote treatment. For our initial studies in this, we didn't dictate at all to the healthcare providers, and in our case, we work with nurse practitioners who are involved in this project, but we didn't dictate what they did. Our goal was just to give clinically relevant information on which they can base decisions. And the rationale at the time was that, especially when it comes to pain, we're very bad retrospective reporters of our pain experience. And that's essentially what was happening in the clinical setting. You don't see a kid, but maybe once a week or once every couple of weeks for treatment. And so you're asking them, what was the last week or last 2 or 3 weeks like for you? So you're not getting accurate data. So our goal was, let's just get accurate data so you can treat better. And in the current trial, we're still not necessarily dictating what care providers do, but we have provided kind of a step. You can do this if this, if this, and so on. And largely what the nurse practitioners do is just kind of get more information. They call up the families and kind of get a sense of, what's going on. Have they, taken their medications or followed through with their recommended interventions. And then they may just suggest something else. Why don't you add on this medication? Why don't you use a heating pad for this type of pain? And they're always encouraging them to go back to the skills training. This would be a good opportunity to practice some mindfulness or some deep breathing. So we do get a report from the nurse practitioners about what they're doing. And our goal over time is to use that information to start to build more kind of structured intervention that healthcare providers can use. But because we're starting from scratch in a lot of ways. We didn't want to start to dictate at the outset without really having a clear picture of what's going on. And part of what we can do, ideally, with the type of data we get from Pain Buddy is, we're going to have 8 weeks of daily symptom data from kids, from 200 kids. We're going to have a massive amount of data. And so what we'd like to be able to do is just build symptom profiles. If a child is undergoing this type of treatment for this diagnosis, this is what a symptom profile might look like. And then that'll help us get more preventive with our intervention.
Yeah, thank you.
Michelle, I think this is really excellent. And currently in CATI 2, we have another team developing the technology, so-called Picard. It's a way to really provide the service to administer the medicine, pain management medicine, so it can capture the data. So maybe there's a way to foster another level of collaboration to address Aviv the questions. So now there's a real-time capture how frequently the kids is taking the medicine and when. At the same time, correlate with the pain bodies data and see whether we can develop some sort of data analytic as a way to really tailor the dosage as a way to be more effective in managing the pain and the health of the kids.
That's what I love about these team science projects and this type of work is it always grows. It just does nothing but grow. So, you know, one of the things we're doing in the context of the opioid epidemic and not having a good sense of opioid use in particularly kids with cancer is we're now taking our pain buddy data and comparing it to more objective data from medical records to see, you know, if a child was prescribed an opioid, what are their pain buddy reports look like, and are they consistent with what they were prescribed? Are they underusing? Are they overusing? And so on.
Yes. Saeed, now it's almost 4.
Okay, I was going to defer to you because I felt I stepped in, but thank you. Can we all, any last minute questions? We don't want you to step away. Miriam, if you have any question, we don't want you to step away into this afternoon and evening and say, I wish I asked this. Now, keep in mind, you can always follow up with Professor Fortier or Judith and inquire more. Any other last minute questions?
And I know someone said their microphone wasn't working. If you have a question and you want to type it in, I can answer it that way too.
Yeah, and answer. Darwin, are you okay?
Yeah, I'm okay.
Okay.
I just have to wear a mask in lab at all times.
Ah, okay. All right. Very good. Can we do, you know, this warm thank you to Professor Fortier, and then you can do the clapping or you can do the gesture part of the reaction, okay? So.
I like those reactions. Thank you, everyone.
We're so grateful to you. We're so grateful to you, Michelle. We really appreciate your time.
Well, thank you, Saeed. And as I said, I'm so grateful for all the opportunities, both for our center and for students through Europe and Cal IT2. And just happy to be a part of it. And don't hesitate, anyone, to follow up with me if you have questions or want to chat about any of the work that we're doing.
Thank you. Thank you very
Thank
much.
you.
Thank you so much, Professor.
Thank you.
Goodbye, everybody.
Bye.
Thank you.
Sonia, if you don't mind, can you stop the recording? And I would like the SURF-IoT fellows to stay